I'm excited to be able to talk about how we've been applying REAIM in some of our faith-based work. And so today I'm going to try to convince you that churches are an important partner for public health efforts to address high chronic disease rates in our country. I'll give just a brief overview of our intervention called the Faith Activity Nutrition Program, and then really spend the bulk of the presentation today talking about how we applied REAIM in this dissemination and implementation study. But let's start with a fun fact. So what percentage of the US population do you think is religiously affiliated? And that's according to a recent national poll. So you can just take a minute in your head to choose from one of the answers. And I'm not going to give you the answer quite yet, but I'm also going to ask you to kind of close your eyes and just consider, do you live within a 5-10 minute walk to a church? And so I recently asked this question at the D&I conference in DC last week, and found that about 3/4 of people raised their hands that they live within 5 to 10 minutes walk to a church. And I asked people to raise their hand if they were in the Southeast, because I thought, well, maybe a lot of people came to the talk because they live in the South and we have a lot of churches in the South. But really the majority of people were from across the country. The picture here on this slide is taken from the sidewalk in front of my home, and it's a picture across the street of an AME church. And so living in the South, we certainly have a lot of churches kind of everywhere, which you'll see as I present some of our work. But here's the answer to the last question. According to a national representative survey, about 77% of US adults are religiously affiliated. And I'm going to talk about churches. We haven't worked in other faith-based settings, but about 71% of US adults report a Christian affiliation. So there's really the potential for substantial reach for health promotion through this setting. If you look at actual participation, about 36% of Americans attend religious services at least weekly, and another 33% attend but less regularly. And you can see on the slide here that what's striking is some of the groups that really do have higher rate of chronic disease burden are also the groups that are more likely to attend religious services at least weekly. There are a few other reasons to consider public health, church health promotion partnerships. One is that churches have, again, broad reach, but also diverse reach. So really people from all walks of life attend church. And you saw a minute ago some of the groups that might benefit the most are also the groups that attend more regularly. Churches tend to be trusted establishments in the community. They're often the cornerstones in people's lives. And if you think in terms of like compatibility of missions, public health and faith communities have some overlapping philosophies. So one is this idea of a service, outreach, volunteer, and health ministry and goal and mission. And the second would be just a more holistic view of health that I think is, again, shared by those two groups, viewing health as mind, body, and spirit. Churches often have physical resources for health promotion, including churches, fellowship halls, classrooms, and even some of the larger churches having exercise facilities and outdoor spaces that could be used for activity or for things like community gardens. And then finally, delivering interventions through churches allows you to tailor the content to spiritual and cultural factors, something you can't really do in generic interventions, but that allows for deeper tailoring and salience of some of the messages, if you can tie kind of the health messages to the spiritual messages. All right, but I would say that overall churches are really kind of undervalued and understudied in public health, and there are some notable gaps in this literature. One is that most of the faith-based interventions have been focused on individual as opposed to organizational change. So really have not kind of captured the potential for looking at policy systems and environmental changes. I sometimes say when I'm talking about churches that even though it's churches, I think a lot of the things that I talk about would apply to any organization, whether it's a work site, a school, because you're really talking about organizational change. Another gap in the literature is that there have not been very many evidence-based programs implemented to large numbers of churches and ready for scale up. So there are a few exceptions. Faithful Families out of North Carolina has been studied in sort of a D&I lens. Body and Soul certainly has. And then the Word Intervention, which is based on the diabetes prevention program, is starting to as well, but not very much. And then I would say implementation, as well as the predictors of implementation, are rarely reported in this literature. It was a few years ago, but Urey's review found that only 9% of faith-based studies reported implementation fidelity. And then when I was working on a paper on maintenance, I really could not find studies in this setting that focus either on individual or organizational level maintenance. So that's, again, very rarely reported. And so those were some of the gaps that we were hoping to fill in our D&I study. So let me turn to a brief overview of FAN, what it's all about. And as Samantha alluded to, this kind of shows you how we came to develop FAN and then now disseminate it more widely. I started working with churches in 2002. I received a community-based participatory research grant from CDC to work with African Methodist Episcopal churches in South Carolina. We were really excited and ambitious. We trained 300 churches. It was overwhelming. We couldn't study much of anything because there were so many churches. So we kind of interestingly scaled down a little bit and got NIH funding, also through a community-based participatory research call. And really worked in close partnership with the church to develop what is now FAN. And you can see kind of on the bottom of my slide some of the accomplishments or where that research led to. When we were thinking about what we wanted to do for our CDC Prevention Research Center funding, so all of the CDC PRCs have to do a core research project. And so we decided to kind of give it a try and see if we could get funded to do a dissemination and implementation study of FAN. And so we were funded, and that's what I'll talk about today. Phase 1 was a county-wide study, a county that's just a little bit north of where we are here at the university. And then we also did a statewide initiative working with the South Carolina Conference of the United Methodist Church. And I'm excited to report that in September, we were refunded to do a national implementation study of FAN, and that's our current PRC core research project. Okay, so what is FAN? What we're really trying to do is help churches to create a healthy church environment for physical activity and healthy eating, with our focus being the current national guidelines for both behaviors. FAN's a really flexible program where churches select activities in each of the 4 components of Cohen's structural model of health behavior and then put it into place in their church. So it's not a curriculum that we give to churches that they deliver to members. Again, churches really choose activities that fit within their culture, their resources, and their characteristics. So an interesting thing that we probably won't have time to talk about, though, is when you think about adaptation, it's kind of hard in FAN because adaptation is sort of inherent in what FAN is all about, being a flexible program. So it's kind of an interesting thing I found to wrap my head around. These are the 4 components of the program. We work with churches to increase opportunities and programs for physical activity and healthy eating, to create healthy church guidelines or policies, to engage and to support their pastor in again, physical activity and healthy eating, and then to get the message out. So we do ask that churches do a few core activities that we think every church could do. So one example is including bulletin inserts that we've created, and they tie scripture to physical activity or healthy eating. So there are a few things like that, but most of the activities that they implement, they choose to fall within these categories. Before I forget, I do want to emphasize that FAN's primary target is the organization and not the individual. So you're going to see, as I talk about REAIM, that throughout we very deliberately prioritized studying organizational change over individual level change. And then the scripture on the slide is just to remind me that throughout our training and materials, again, we do really build in sort of the biblical ties and basis for our messages. Okay, so briefly, in D&I language, our major implementation strategies would be training, technical assistance, tools, and church committees. So USC identified and trained community health advisors from the churches to then train church committees to implement the program in their churches, and they provided technical assistance as well. So that was a major change from our R01, where our staff trained churches to implement. So we asked that churches create a committee. The committee attends a full day in-person training. And then during that training, they begin to develop a program plan for what they'll do over the next 12 months. Again, very much tied to those 4 core components. They complete the plan after training and submit it to us. And then we ask that they do a few things to get started. So first, to hold a kickoff event to get the church kind of excited and to understand what FAN is all about. We encourage them to meet regularly, ideally monthly, to plan their activities. And then they talk with their community health advisor monthly for brief technical assistance calls. And those are really about 10-minute calls, so they are quite brief. Okay, so that's what FAN is. Now let's talk about REAIM and how we've used REAIM in this study. And I'll just warn you, I have a lot of information. I may move through some of it pretty quickly. So in this project, again, phase 1 refers to our county level project, and that was a group randomized trial. So we randomized churches 2-to-1 intervention to control. And then the statewide study was quasi-experimental. There was no randomization, so all churches received training in the program. Our study aims for the grant were really to use the REAIM model to just study these components in REAIM. And then we did also use the CFER to look at factors that predicted or influenced adoption, implementation, and organizational maintenance of FAN. Okay, so let me talk through the methods for conceptualizing and assessing the REAIM components, and I'll point out when there are differences between our phase 1 and our phase 2 studies. So for adoption, the main task was to define our denominator. In phase 1, we did a comprehensive audit to identify all churches in the county, and we worked very closely with the county coalition to do that work. In phase 2, we were kind of lucky because we worked with the South Carolina Conference of the United Methodist Church, and they were able to share with us a file of all of the churches as well as some basic church information. So we could use that as our denominator. Once we knew the total number of churches in the county or the state, we just defined adoption as the percentage of churches trained over the total number of churches in the county or the state. And then we were also able to compare adopting and non-adopting churches along a number of the characteristics that you can see on my slide. For REACH, we really used the estimated attendance data, either that the church reported in the audit in phase 1 or that was provided by the conference in phase 2. And we just summed those numbers for adopting churches and compared it to the total numbers if you looked at all churches in the county or the state. And then in phase 1, we could also make a comparison with REACH relative to the county census. That really wouldn't have worked in the state level because it was limited to one denomination. We only assessed effectiveness in phase 1. So we conducted on-site church visits. We did many, many trips to Fairfield County. We came right after worship service and administered anonymous member surveys 9 to 12 months after the intervention churches were trained. So this was a post-test only model, admittedly somewhat weak. So the surveys were administered to members of intervention and control churches. And we looked at health behaviors, self-efficacy, and then member-reported organizational change. So we could compare how members viewed their environment and then the implementers, what they reported they did to the environment. For implementation, it was assessed the same way for phase 1 and 2. So we conducted baseline and 12-month interviews with the church coordinators. So those were the people that kind of coordinated their church committees. And we did that for the intervention and control churches for phase 1. And they simply reported the frequency with which they did the 4 core components. It wasn't that simple. It wasn't 4 questions, but that's really what we were looking at. We calculated mean scores for implementation separately for physical activity and healthy eating. And then we also, a priori, selected criteria that we defined as high implementing, and also looked at that more dichotomous definition of implementation. For maintenance, we relied on the 24-month interviews with the church coordinators. And because in phase 1, we essentially trained the control churches a year after the intervention churches were trained, we couldn't really use their data for maintenance. So we just had to use the intervention churches. And then we did the same thing. We had mean scores, and then we had criteria for maintenance. We did use somewhat different criteria for maintenance because as our team was looking at some of the items, and I'll just take one as an example. So one of the things Fan talks about is having the pastor share messages about physical activity and healthy eating from the pulpit. We realized that doing that over time, so after a year, probably our criteria for high implementing is not realistic in that setting because their mission is really not physical activity and healthy eating. So we loosened some of the criteria like that, not all of them, to say, you know, if they were doing it regularly, every couple of months, we would consider that maintenance of sort of the essence of Fan, if you will. Okay, so let's get to the fun stuff. My goal is to present a snapshot of each component of REAIM, which is a little bit ambitious. I'm going to sacrifice a little detail in doing so, except for on this slide, which has a lot of detail. So this slide shows you adoption and reach for phase 1. Our audit identified 132 active churches in our target county, and of these, 54 met our definition of adoption. They were trained, and then one additional church who was considered too small, but we opened up training to any church, even if they didn't meet the criteria for size. So we were really excited that in the county, 42% of the churches adopted Fan. And our reach, it's a fairly rural county, was estimated at about 3,500 people. We found that adopting churches were significantly more likely to be primarily African American congregations, and also much more likely to have taken part in a previous countywide initiative. It was not one that the university did, but it was in the county, and it was focused on tobacco policy. So they may have just been kind of more ready to take part in another health initiative. In phase 2, these numbers are a little bit still in progress, but should be pretty close now. There are almost 1,000 United Methodist churches in South Carolina, and you can see here that our adoption rate, 115 adopted, so that's about a 12% adoption rate. The reach is estimated at around 46,000 members, although the number is going to be lower for people who attend regularly. And again, we found that adopting churches were more likely to have African American congregations, somewhat more likely to have an urban RUCA code, and more likely to have 500 or more members. Okay, let's turn to effectiveness. Again, we only have this for phase 1. Our church visits, we had around 1,300 people complete surveys, and we really had a high completion rate. We tried to have the data collection team count how many people were at the worship service. I don't remember the number, but it's probably close to 80% of people stayed around and took the survey. So again, we're looking at the member rating in intervention versus control churches, just at post-test, and all analyses controlled for members clustered within churches. So for our intervention targets, again, those are the things, the opportunities, messages, and pastor support. We saw large differences between intervention and control churches that were all statistically significant and large effect sizes, except for healthy eating opportunities. What we actually found was that both control and intervention churches reported that they frequently had fruits and vegetables when food was served at church. So there was kind of little room for change there. For self-efficacy, you can see our effect sizes are small. They're in the right direction, but only approaching significance for physical activity. For the percentage of members reporting that they're inactive, it was lower, which we want to see, in intervention compared to control churches. And, you know, I think you take it with a grain of salt. It's self-report. I'm guessing a lot more people were inactive than what we had there. But unless you'd expect the bias to operate differently, I think it's consistent with what we're trying to do in the churches, which are things like building in physical activity breaks and that sort of thing. Meeting fruit and vegetable recommendations was in the right direction, but very small and not significant. And so what we're seeing here is a pattern we saw in our R01, and we're seeing in kind of all of our studies, which is the effect sizes for organizational change, which is really the target of our intervention, tend to be large, medium to large, whereas for individual behavior change, small. And these effect sizes are pretty similar to our R01. We just had fewer churches. So we can talk more about that if you're interested. Okay, let's move to implementation. Again, this was looked at the same way for phase 1 and 2. And we're looking at 12-month implementation, controlling for baseline levels. And so you're starting to see a really consistent pattern here. The mean levels are effect sizes for physical activity and healthy eating, again, with the exception of vegetables, you know, which they're all serving. Who knows what's on those vegetables? You can see medium to large, and in this case, really more large effect sizes, which indicates change, positive change over time. When we applied that dichotomous criteria of whether a church met criteria for being a high implementer, you can see that for physical activity, across components, it ranged from 37 to 60%. For healthy eating, 51 to 71% met that criteria for high implementing. Okay, and then finally for maintenance. Again, here we're looking at the 24-month data limited to intervention churches. And what these effect sizes show you are baseline to 24 months. So again, we're seeing medium to large changes from baseline to 24 months. A little bit smaller, as you typically see in intervention studies, but still pretty sizable. And when you look at the criteria of maintainers for physical activity, it ranges from 42 to 70%, with the majority of churches being considered a maintainer on at least one component of FAN. For healthy eating, it tends to be higher, so 52 to 94%, and the vast majority maintaining at least one component. And if you think about this church structure, churches very typically include food, and so we're really asking them to make modifications as compared to physical activity, where often it's starting something new or kind of a new organizational practice, so it's somewhat lower. Okay, and I just have some concluding thoughts. I have a couple questions that, you know, if you wish to answer, I'd love to hear, and then some of our next steps. So one of the things we've thought about when we look at reach in this setting is that we may be underestimating reach a little bit. And I say that because, for a couple reasons. One is when you look at average attendance in church, and if any of you are churchgoers, what you'll see is from week to week, you might have 100 people week 1 and 100 people week 2, but they may not be exactly the same people. So you probably have more than 100 people who are attending, semi-regularly. And then also we found, and especially in African American communities, the average churchgoer tends to be a middle-aged woman. And she's likely a gatekeeper in her family and her community. And so it's just kind of an interesting idea to think about with reach and how broad messages might be reaching. I would love if you have any idea for journal outlets, especially for our implementation and maintenance findings. And then I have some ideas for why adoption rates differed so much for phase 1 and phase 2, and I'd be happy to talk more about that. I guess the brief answer is, in phase 1, we were really focused on a much smaller area. We employed someone in the county who did a lot of our recruitment, and she's someone who's well known. She was an African American woman, and it just seemed like that personal contact was really important in the churches. With the statewide initiative, I did go and I visited all 12 of the districts in the United Methodist Church, but it's just a different sort of relationship and dynamic. So that's another idea. I kind of alluded to the idea that when you think about criteria for implementation, at least in, I think, this intervention and in this setting, it might need to differ some than the criteria for maintenance. And I'd love to hear if people have any thoughts about that. It's not just my opinion. I think other people view implementation this way, but I think it's really hard to think about implementation as a dichotomy. I mean, even in our project, we have 4 different components. We have churches that went from doing practically nothing. So they may not reach that level of implementation, but they still might be making some real differences in their church. And I think that has implications when you try to look at implementation relative to your outcomes. Our timing of papers is sometimes a little funny. Like, I think I'll be reporting on implementation before our adoption paper comes out. And that's partly because of who's leading the paper, how hard the papers are to get published, and all of that stuff. And then I just want to remind you, as you think about FAN, that we're really focused on organizational change. We didn't recruit a cohort of people who then were part of a curriculum or an intervention and then study that same group of people. We really try to survey like the whole church with the idea that if an organizational change occurred, then really people should have been exposed to it. But I think it's important to think about when you're considering effect sizes. And so I'll just conclude with the questions and thoughts and saying that even though I think we applied REAIM somewhat simplistically in this project, it was a very useful framework to think about our intervention and how we were doing, and thinking about individual versus organizational variables and really the public health impact. So next steps. The thing we've been really encouraged by is that FAN has shown a very consistent pattern of findings in our R01 versus the countywide versus the statewide D&I study. And so we're taking it to scale, whether we're ready or not. We've been in the process of converting our in-person trainings to interactive online modules. I could probably do a whole webinar on the roller coaster ride that has been. We're going to be piloting those modules in February and then hope to roll out the implementation study nationally in the fall. And so a shameless recruitment plug, pass along our website if you know of churches in your community that might benefit from a program like this. And so I'll just end with thank yous. So a huge thanks to Fairfield Forward, which is the community coalition that we worked with in Fairfield County, the leaders of the South Carolina Conference of the UMC, who were extremely helpful in getting us access to the churches and really promoting and supporting FAN. We had great pastors and lay leaders who participated on the church committees. Our community health advisors were awesome. They did as good of a job as our staff do, it appears, from our outcomes. And then I want to thank faculty, staff, and students at the USC Prevention Research Center, especially Deborah Kennard and Jessica Stucker. And then just to acknowledge that we were funded by CDC, but everything I shared today was my own view. So with that, I think I'm done, Samantha. Should I take it off of, you can steal it.
Yeah, feel free. Either way, maybe somebody would like to go back to a specific slide, but either way, well, thank you so much. And feel free to start adding questions to the chat and or unmuting yourself to ask any questions. I'll just start with some reflections on my side and then open up for anybody, but it's just so inspirational to see 17 years of work and how the evolution has come. And as you said, there could be multiple webinars on even building the partnerships or building the modules or like all of the moving parts. My question might be a little different, particularly as many of the people on the call are just coming back from the Dissemination Implementation Science annual meeting in DC, or I guess in Arlington. One thing that came up in some candid conversations multiple times was this idea that particularly as junior investigators and potentially across the board, where you feel like you're throwing out grants and just throwing spaghetti against the wall and seeing what sticks. And some people have, asked very pointedly, should I go for the R01 for the new investigator bump, or do the R21 first, or the R03? And the CDC sponsored, or funded the first round of this. Could you give a little bit of information about how you strategically saw the path and then were able to be so successful and get this registered with our tips and all of those kind of bigger picture pieces before we dive into any further details?
Sure, although I will have to say that my nice linear picture, the true picture would have been like a big mess of stuff. So I can't, it definitely was not conceptualized that way. But I will say that a couple thoughts on your question. One thing is that from the very beginning, we've always prioritized community input. And so even developing FAN, I think, the research team would have liked a somewhat more intensive intervention and probably even more training, but we really tried to listen to what was feasible from the church and kind of what they wanted. And I think it's just served us really well, because I think even though we are not seeing large effect sizes, I think it really does have the potential, if you think about the re-aim multiplier, the reach times effectiveness, of being feasible and being scalable. So that was just from the start, I think we thought about dissemination and how we would like this to not be a research study that can't be replicated. But that did mean listening to the community. In terms of like the funding issue, so much of that is really opportunity and good fortune and good timing. So when we first started working with the churches, CDC was putting out more independent calls for research, which is not something you're seeing too much anymore. So it was a great opportunity to kind of go in without really much pilot data or anything like that, and then apply for the R01 level funding next. So, I think you have to be realistic and probably start with something, if you don't have the pilot data, to start with something smaller scale, like an R21, or even smaller, to do some of that community building if possible, and just think about how you want it to grow from the very start, so that you're hopefully collecting the information that you kind of need to show that. I don't know if I answered your question, because it was not maybe as planful as my slide might have shown.
Yeah, well, I think even just sharing that is helpful, because I think a lot of us are thinking, well, why isn't it going in this particular direction? And it's nice to know that
Right.
It maybe didn't, but we still got, those impacts and those connections. So does anybody else want to unmute and ask a question?
Yes, can you hear me?
Yes.
Sarah, it's Russ Glasgow.
Hello.
First, congrats, Samantha said. And I just want to say this was not at all a simplistic application of your name. I think you illustrated a number of both fairly sophisticated issues and some really good questions coming up at applying REAIM. So thanks for that.
Thank you.
I have both a comment and then a question. But first, if you can, I'd suggest maybe you go back to the slide about your questions that you had. That might prompt, other people, and so our discussion can focus on some things you'd like it to.
Okay.
My comment, both the comment and the question have to do around issues of implementation and adaptation, which we're seeing in the field in general, and as well as REAIM, an increasing amount of interest. And my comment is, in thinking about how FAN was flexible, to me this kind of hit home with this new conceptualization, at least for the U.S., that Brian Mittman is pushing about distinguishing between form and function.
Yeah. Yep.
And I think as opposed to the way we used to think about it, or I don't know, it's maybe still controversial about core components, but it just struck me that it really fit this notion about the function of what you were delivering and how FAN was, not like you have to follow every item in this protocol, this fixed protocol we had. But
Yes.
I just comment, I don't know if you have a reflection on that, but my question for you related to adaptation had to do particularly with the maintenance. And I thought it was neat you could go out to 24 months. But I'm just wondering, how much adaptation did you see or changes in the churches, during that period of time? And were they, sorry to go on so long about the complex question, but not only the changes, but like what, if there were adaptations, what types of changes did you see?
Sure. Well, those are great questions. Maybe just a reflection on the form and function. I think you're absolutely right in terms of, the form, these kind of core components, but the function, so churches can really meet those core components or forms or whatever in a variety of different ways. So I think that does fit well. In terms of adaptations and changes, so I think one of the big limitations in how we've done our evaluation is we've collected pretty high level information. So examples of items that for how we would assess implementation and maintenance would be something like how often are fruits and vegetables available when meals and snacks are served at your church. So with that type of question, we're not really getting at exactly what did they do, but just are they providing that opportunity? And so we did collect, from some of the technical assistance calls, we do have some information about what they're doing in a little bit more depth. So it makes it hard to answer your question because we kind of just have their ratings of some of the core components, if that makes sense. And I'll give you a chance if I can follow up more, because I don't feel like I really answered.
No, I think you did. And again, I think both within REAIM and in general, this illustrates a number of, real current issues and changing conceptualizations and things like that. I'll stop and let others have a chance to enter in here. But thanks so much for doing this, and congrats on a really nice series of research studies.
Great. Thank you.
Yeah, Sarah, this is Paul.
Yeah.
Really nice. It's so fun to watch how your work's evolved and see you talk through it rather than just read it in the paper. So thank you. I think there's a couple of things I wanted to throw out. First of all is you asked about outlets for where the implementation work could go. And I'll give a little bit of a plug, although we're kind of closing the the deadline on this relatively soon. We're doing a Frontiers of Public Health collection of REAIM related articles.
Oh.
And so Samantha has pasted that in the chat, so you can look to the link there.
Okay. Great, thank you.
Sure. And then the second thing is, if you weren't doing that, preventing chronic disease, we've been pretty open to implementation evaluations and moving into implementation research. So that's a good spot too.
Okay, great.
Okay, and so my question was, and again, I thought this was just great, and it might be touching a little bit on some of the things Rust asked, but I'm thinking about the maintenance, and I saw a really interesting talk at the D&I conference where they were talking about cost. Mm-hmm. And it was in clinical settings, and they demonstrated that temporally the cost of implementation decreased over time. And their hypothesis was that as people become more skilled at the implementation, it takes less time. Mm-hmm. And you found that when you got to the maintenance phase, that maybe you were asking a little much of what you wanted them to sustain. Do you have, so I'm kind of trying to pull all that together and think, do you have an idea about cost in terms of even just time from the folks that are doing this implementation, and how that might have changed in terms of even the kind of what the churches wanted to do as the study progressed?
So I love your question, because in our national implementation study, we do have a health economist. And so we are collecting cost data. And so that's a really interesting thing for us to think about, that the cost may change over time. For the studies I presented on today, we don't really have measures of cost, whether it be time or money, for implementing FAN. But I will say it very much more qualitative, kind of anecdotal sharing. We have, especially in phase 1, where it's the countywide initiative and we're still very involved in that community coalition, we've had the opportunity to kind of bring churches back for quarterly meetings and hear how it's going. And the churches that I think were successful in implementing really talk about how FAN is kind of, it's just part of how they do things now. It's sort of part of their culture and the fabric of the church. And some of them probably don't even think of it so much as FAN anymore. They just think of it as, we provide these healthy options. We have an activity break when we have meetings. And so I think your point is a really good one, that, for those churches, that it really probably is not the same cost of implementing over time. But I don't have any data, unfortunately.
Yeah. No, thank you. I'll give someone else a chance to.
We have one question in the chat about whether or not you assessed organizational readiness at the beginning.
So we did measure a lot of CFR constructs and domains, including, and I'd have to kind of go back and pull, but readiness was one of the constructs we assessed. But because we were trying to kind of capture many of the CFR constructs and also not overwhelm these churches, often we use just a single item or two. But that is one of the things we looked at, and we did, not to go into the CFR too much, although they're all kind of related, we did try to time those measures so that if we could assess something before training, we did, things like the culture of the church, things that they had to know some about FAN to answer, like the what they thought it would cost, the time, the adaptability. We assessed that immediately after training. And then some items, they really had to have implementation attempts to evaluate. So things like how well was it received by their congregation, and those we assessed at the 12-month point. But we did have some, at least a couple items for readiness. I don't think they were predictors of implementation, though.
Thanks, Sarah. The next one is, did you get any criticism for not getting standardized individual effectiveness outcomes and clarity that criticism from both journal reviewers as well as your funders?
So, yeah, I think ultimately people want the individual level outcomes. And we have, I guess, because we've been funded, we've been able to successfully make the case of why we're prioritizing organizational change, because it really is an organizational level intervention. But ultimately, it's for the purpose of improving individual behaviors. So, yeah, the paper that we have published so far had both the effectiveness and the implementation, or really more of the organizational level change in it. And we are working now on trying to publish some of our papers that will not have individual level data. So I guess the jury's out, but I anticipate that those papers are probably going to be a little bit harder to publish.
Thank you.
Sarah, I'm going to jump back in since there's no other ones on the chat that I'm seeing anyway. From the time that you started this and moving forward, there's been a lot of advancement in measures, related to the explanatory constructs for how things might get adopted, implemented, and maintained. Going forward, do you have ideas on how you would try and do some of this measurement stuff differently than you did as things have advanced?
I don't know, but I'd certainly be willing if you have thoughts to hear them.
No, I'm always struck by, like you said, when we think about the burden from, we're working with systems to try and get them in the first place or we're trying to support them to see how best they can get these things implemented and sustained. And then, we're trying to do this implementation research over top of that. And, many of the measures are really long. And, and so I didn't have any specific thing. I just thought maybe, you've started to look to see what's out there. And if you had ideas on how you could be a little more pragmatic with assessing things like organizational culture and leadership. And
yeah, I will say that as we do the national implementation study, we will definitely be looking at, for example, the CFR items that seem to have the most promise, or the constructs that seem to have the most promise, and then the ones where it was, ZIL, NIP, null, nothing going on there. Now, we have to be a little careful because we've been doing this work in South Carolina, and there may be some things we will want to continue to assess because the larger literature says they're important and to see in a national study. But I think that's where some of our pruning will occur. It's, honestly just, something I've always struggled with in this work is balancing just the amount of time and effort it is to get, in this study, 59 churches randomized and then 115 churches that we're assessing. Your measures suffer a little bit because we don't have the money to do on-site visits. And even in a faith-based setting, that would be kind of hard to do because, all the different things you're trying to change. So I think you have to kind of go in just being honest that there are definite limitations with these measures. But on the other hand, I think we're learning things that we wouldn't be able to if we focused just on 5 churches and studied them really carefully and with state-of-the-art measures and all of that. So it's definitely a trade-off.
Yeah, that makes a lot of sense. Thanks, Sarah.
Mm-hmm. Okay, another question is your thoughts on whether this would work in any church, not just AA churches.
Whether it would work in any churches, just not
just AA churches, yeah.
Okay, so not just African American churches. So yeah, in the statewide initiative, although we had higher adoption in African American churches, we still had a sizable proportion, more churches that were predominantly Caucasian churches. And we actually did find greater effects in the African American churches, but we're still seeing the same pattern. So I don't think that it's specific to African American churches. The only thing I will note, though, is why I think we're seeing higher adoption and maybe implementation is sort of a even more holistic view among African American churches. You know, and when you think of the history of Black churches in a lot of places, but especially in the South, that they have traditionally advocated for a lot more than just spiritual health issues, right? When you think of civil rights and just all sorts of things like that. And so I think when I've gone out into churches, I think there's a greater view that the church needs to do something to address health disparities, and that's more salient in the African American churches than in, you know, predominantly Caucasian churches. And in South Carolina, that's kind of what we focus on. We do have a growing Latino population, but it's very small. So.
And I have a comment to please from Marcia to really encourage you to try the Frontiers research topics. So I sent that chat, and I'm happy to send that to you directly via email as well. And then another question is whether or not you have data or just anecdotal feedback that the churches that did engage in these kind of organizational changes, did that increase the number of people who came to that church for any reason, or do you have any information on that?
Yeah, I wish we had information, because churches would really love that. I think that would be a hook for churches if they could increase membership. When we first started partnering with the AME Church in South Carolina, you know, back 2002, some of the leaders were excited about the program because they did think, you know, it was almost kind of a relative advantage or a competitive thing that they would have a fan at their churches, and especially for younger members, which in churches we know that's the demographic that's not as active in churches, that might be a way to kind of draw them in, but we don't have any data, even really anecdotal, to know if that's true or not.
Yeah. That was my fun thought.
Yeah, I like it.
Any final questions from the group? Anybody who hasn't had an opportunity to ask, or anybody who has had an opportunity to ask, want to ask a final question?
Thanks so much, Sarah.
Oh, thank you. This was really helpful. The questions got me thinking. I took some notes, and I just might have a paper ready to submit to Frontiers. So I will follow up on that. Thank you.
That would be great. Thank you so much. I want to reiterate what Paul said about like just seeing it live instead of as a piece of paper that you're reading, you know, on an iPad or in the car or at your desk. And for everybody else that's on, thank you so much for joining. I hope you have a great end of the decade. And I hope that you'll join for our next REAIM webinar, which is on February 13th, where we will have Russ Glasgow, Gila Netta, and Bailey Hotailing talking about their experiences at the annual Dissemination and Implementation meeting, just kind of reflections from the field and some of the conversations and things they left really reflecting on. So we hope you'll join and perhaps share some of your experiences. And again, feel free to email me with any REAIM webinar topics that you'd like to see, and please spread the word. Thank you so much, and have a good afternoon, everyone.
All right, thank you. Bye-bye.
Thanks, Samantha.
Bye, everybody.
Bye.
Hey, Paul.
Yes, ma'am.
Whenever you download that, if you want to email it to Thomas, that would be great, and he'll get it uploaded.
Sounds perfect. I'm sure it will download as soon as I end the meeting.
That sounds good.
Okay. See ya.
Talk to you soon. Bye.